Want to wait for 2 minutes and then begin as
That's
the
fine.
participants are joining.
I always thought we should have sort of like a band in the background to play music while we're waiting, for everything to start.
Everybody to join. Yeah.
Exactly. Yeah. Yeah. Let's work on that.
Yes, maybe next time we should do it.
Okay.
I think every time we should have room to improvement. So I take this.
Yeah.
Yeah, I think we'll start. People will join. So,
Okay. Perfect.
yeah. Good evening, everyone. A warm welcome to this insightful session on manual therapy for voice and swallowing disorder. We are honored to have such an enthusiastic participants with us today. Before we begin, let me introduce myself. I'm Preeti. I'm an assistant professor at Kasturba Medical College, Mangalore, and also an assistant professor of research at University of Toronto. As many of us know, SLP Quest is led by our dear friend Prasanna Hegde. He has been at the forefront of advancing speech language pathology and deglutology in India. It is with great excitement that SLP Quest is now introducing manual therapy for voice and swallowing disorder for the first time in India. This initiative will take place in November 2025 with exclusive workshops on November 13th to 19th across Mumbai and Bangalore. This marks a significant milestone for the field of speech language therapy in our country. Before we begin, here are few housekeeping announcement. I kindly request all the participants to ensure that their microphone are muted to maintain a clear and distraction-free environment for the entire duration of the program. If you have any question or comment, we encourage you to raise hand, which is a feature on Zoom, or you can type in your questions in the chat box. We will surely take it during our question and answer sessions. Now, it's my absolute honor to introduce our esteemed guest today, Walt Fritz. Walt is a licensed physical therapist with a BS in physical therapy and a BA in community mental health from State University of New York, Buffalo. He has been practicing myofascial release since 1992 and is one of the most experienced practitioners in Central and Western New York region. Over the past decade, he has further developed his techniques, leading to what is now called manual therapy. His contribution in the field include presenting at international workshops through his foundations in manual therapy seminars, publishing the book, and contributing to leading research in the field. Today, we have the privilege of learning from him firsthand. Thank you for being with us today, Walt.
Thank you for moderating this, Preetie. I'm looking forward to our talk.
Thank you so much. So, as we begin, I would ask you about your journey. So, what led you to establish this manual therapy practice?
Oh boy, do we want the long story, the medium story, or the short story?
Short
Um,
story. I'm sure we're
okay,
going to
great.
hear you again. Yeah.
That's yeah, and you'll hear a lot from me about this.
Yes.
Essentially, I'm a physical therapist since the 1980s when manual therapy was exceedingly common in physical therapy. It's diminished since then, but I learned it as a viable means to help people. And I took a lot of manual therapy trainings back in the 1980s, 1990s. And I started first working for an educator teaching myofascial release. And then I started to teach on my own in the middle 2000s. But in 2013, I was invited to a one-of class in Chicago, Illinois, in the United States to help teach a course for speech pathologists on myofascial release for voice and swallowing disorders. And sorry, I just have to reorganize my screen here. Okay. And that basically was a door that opened for me. It's the first time I'd ever presented in front of speech therapists, speech pathologists. And while I think my talk went fairly well, I realized how little I knew about your field. And the one thing I want to make clear is I'm a physical therapist, not a speech pathologist. I don't pretend to be one. I see myself as sort of um, possessing a group of skills that I'm very willing to pass across a bridge to people like yourself and allow you to adapt it and modify it for the individual populations. I'm not going to teach you how to be a speech pathologist with manual therapy. I'm going to hopefully open up curiosity in your mind to say, hey, this might work with my patients. There's a lot of good evidence, and we'll talk about that. But it also takes, I think, the courage and initiative of a professional who was not initially trained to use manual therapy to feel like, number one, it is within their scope of practice. And number two, it's okay to begin using it as long as we're aware of the cautions, the dangers, etc. So 2013 started this journey. And then, I don't know, about 3 years ago, I completely stopped teaching almost all my other classes for massage therapists, for physiotherapists, because I really like this field that we're talking about right here. And it's basically, I'm in my mid 60s and it feels like I started a new career recently, which is pretty exciting.
That's great. I was about to ask you what are the key misconceptions that we have about manual therapy. You have addressed that too. And I think
Well,
we are
yeah,
all somebody who is looking into something new which can benefit our patients, which is evidence-based. I think that's
right.
great that we are getting introduced to it here in India for the first time. Thank you very much for
Yeah,
briefing.
I do want to add something to that question though,
Mm-hmm,
about the misconceptions. I believe, okay, so I've been in this field for 4 decades, that
mm-hmm,
one of the big misconceptions is that manual therapy, and whether we're talking about vocal massage or laryngeal manipulation or myofascial release or some of the other terms that this work is called, one of the key misconceptions is it's about the skill of the clinician finding and fixing the tissue-based problem. That is the historical narrative for myofascia, I'm sorry, for manual therapy, whether it's the fascia, the muscle, the nerve, et cetera, right? Including most of the laryngeal manipulation research published in the speech pathology field over the last 40 years. But when you look outside the speech pathology literature on manual therapy, you're going to see a beautiful evolution of underlying mechanisms are seen as not just about right here or right here in the tissue, but we're seeing it as truly a whole person interaction. And to me, to some people, that really confuses the work. Wait a minute, if I'm not breaking up muscle tension, what am I doing? And there's a paper that I didn't quote it in the references, and Preetie, you're going to be sharing my references with the group, but there's a paper by Tommaso Geri, Geri, and he has a quote that I am so fond of that it's at the top of my Facebook page. Clinicians should remember that manual techniques are not tools to fix the patient's body. Rather, they provide the opportunity to communicate with the patient's brain, similar to words. And that's how I embrace manual therapy. That's how I use it here in my clinic. And that's how I teach it. That while we think it's about what we're doing with our hands or our fingers, and it is, it's really about the connection, the awareness that we're building in our patients.
I think that's a great point because I think we should be knowing where are we beginning with before we start with intervention. Whatever we begin, I think that's going to make a difference, definitely.
Yeah.
So,
I and by the way, in the chat section, I forgot to put it on the references. There's a paper that I published early last year that really summarizes my approach to the mechanism of action of this work. Not about, fixing something out here in the periphery, but a multifactorial and often very complex and confusing collection of possible ways that we're engaging another person's central nervous system awareness.
that's great. I think the participants can note there are references which is being added to the chat for further reading. And again, all this would be possible. You'll be able to practice it with the certification. So I think that's what you'll have to take it.
Yeah.
Evidences are very much there. Yeah.
Yeah.
So if I look at what are the effectiveness or scope, can you highlight what are the various conditions to which manual therapy can be used? And in your experience, for which condition, which are the population who have best benefited with manual therapy?
Okay. So, Preetie, here's where I'm going to drop back and remind people that I'm a physical therapist, not a speech pathologist. In my clinic here in New York, I get referrals from speech pathologists. I get them from surgeons, ENTs, et cetera, but I also get referrals from my website, and which means somebody could be coming into me for a voice issue, a swallowing issue, an airway issue. But I only treat a small fraction of who you see on a daily basis. All right. So I rely vicariously on feedback from therapists who've taken my courses in the past. What are they seeing? What are they having luck with? Certainly, we're looking at the evidence, right? The evidence for muscle tension dysphonia, that's been proven since, well, the first study was done in 1993, but now by Nelson Roy, proven that manual circumlaryngeal treatment, laryngeal manipulation, is an effective tool with muscle tension dysphonia. But you've now got newer literature bringing it into, well, muscle tension dysphagia, but head neck cancer related dysphagia, tongue disorders, airway issues. Those are all real key components of how I see this work as being effective. I'm not quite sure how things are in India, but in the United States and the UK, there's a niche of clinicians who practice OMT, orofacial
Yes.
myofunctional therapies. Yeah. And that's it often is a very exercise and cognitive behavioral training type of approach. Beautiful work. We've been able to sort of mesh in with that OMT approach, adding manual intervention with that exercise based approach. And there's a lovely paper that I put in the references. Let me see if I can pop it up real quick here. Oh, I apologize. I can't quite see it here, but there's a reference in there that I just added today on OMT combined with manual therapy, how it actually improved outcomes. So we're talking about tongue posture. We're talking about articulatory issues. We're talking about both maybe surgical or radiation induced articulatory disorders. But one, I think, the underdeveloped ones in manual therapy is articulation delays or disorders resulting from a developmental disability, a head injury, a stroke, etc. And some of it, it's almost too simple. You gently hold a person's tongue. You can call it stretching if you want. We talk about the difference between holding and stretching, right? That it's not about pulling or lengthening a tight muscle. It's about providing tactile stimulation to an area, whether it's the tongue, the mouth, the throat, wherever, to basically build a sense of inner awareness on the patient's part. Can I give a sensory input that goes back up to the brain and results in an altered motor output? And that's truly what the basis for this work is.
I think that's great. Thank you for highlighting that it is something effective for various disorders, may it be head and neck cancer, may it be neurological disorders, and also you highlighted something on patients who is undergoing radiation therapy. So,
Mhm.
how does this manual therapy support recovery in patients who have undergone radiation therapy?
Yeah, so I'm going to cite two studies right now. One, both of them are by the same lead author, Gintis Krishunas with a K. In 2015, they did a five-person case study. Now we know where case studies lie on the evidence ranking, but they what they did was the test was they wanted to know would manual therapy be tolerated during the course of radiation. And what they found was not only was it tolerated, but it actually attenuated or decreased pain levels in people while they were receiving the radiation. And there was also a secondary benefit of improving neck range of motion during the course of radiation. All right. And then Krishunas did a follow-up study in 2019, which was a survey study of speech therapists who are using manual therapy. And they talk in that paper about some ancillary, some research that's been done on the effects of touch, on manual intervention, on the progression of fibrotic change. And they found that based on a lot of interesting, neurohistological, et cetera, that manual therapy can actually reduce and the potential for that runaway inflammation effect that fibrotic changes can have. Now, it's not dosed and it's an early paper, but it's enough evidence that Krishunas and her team thought was, here's something that you may want to consider both applying it as a clinician as well as teaching your patient to do on a regular basis. And while they don't say it, it's for the rest of your life, right? You might be able to mitigate some of that progressive tightness through just a slow, sustained daily stretch. And to me, those are the kind of studies that I really look for in
Mhm.
terms of high quality RCTs on fibrotic change. I've not seen a lot yet on manual therapy when it comes to your particular field. Although if you go out of your field, for instance, into the breast cancer research, you're going to find studies on that. Does breast cancer research directly apply to head and neck cancer research? Well, not necessarily, but in other ways, I think it does. If we're talking about the application of an intervention to improve pain, improve flexibility, improve function, I think we should look outside that little world that we tend to exist in and see what other
Yeah.
people are saying about it.
Definitely. I think that's great to look at and draw ideas or draw conclusions from other research and what can be applicable to our field. That's great. So,
Yeah.
since we're talking about who are the population who can benefit with manual therapy, is there anything that we have to be cautious about? On whom do you think we should avoid manual therapy or we have to use it with caution? Any voice or swallowing disorder that you think we have to be vigilant about its
Not a
application?
specific voice or swallowing disorder,
Mm-hmm.
but the first thing is I need to evaluate my patient. Do I trust them to tell me what they're feeling? Whether that's a cognitive ability, whether it's a communication ability, or whether that's a belief that it has to hurt to help. Because in my practice, some patients come into me expecting what I do to hurt them, right? Oh, that hurts a lot, but I hope it helps me, right? While I understand that mindset, I try and just get rid of that right away. Do I trust the patient to feed back to me? Do I trust the patient to tell me what they're feeling, those sorts of things? And I'm not necessarily talking about nuanced full communication. I work with, I spend part of my physical therapy years in early intervention. I can't expect that sort of communication. But can my patient, pediatric, geriatric, or somebody in between, can they give me some feedback as well as their
Mm-hmm.
preferences? I look for those basic safety nets, right? But I also look for, fresh surgery. How long should we wait? It's a really tough question. But when I ask surgeons that question, based on them coming to my class and saying, okay, I know what Walt taught, it's interesting because when I've asked a question to surgeons who've been in my class, they've all come up with the same number. And they'll say, well, and I use thyroidectomy as an example just to keep things equal. And they said, based on what we did in this class, I would say I'd want a therapist to wait 6 weeks before we worked this area, right? Now, that's not the answer, but at least it's a more guided answer. You're still going to have things that get in your way in terms of, healing, other comorbidities, patient response, et cetera. Those are things that I look for. Radiation, I don't think we should be waiting unless the patient can't tolerate it. Other things, the uncertainty of a diagnosis are certain things that we need to be aware of, right? And if you're not sure, you talk to your physician, you talk to the referring physician to see what they have to say. Um, I look at patients' response to touch. And
Mm-hmm.
some people, when you use touch, there's almost this affective response of they're being heard, they're being listened to, they're being cared for. On some people, it's the opposite. There's a sense of fear, right? They just got cancer taken care of. I come in and want to touch their neck. They may not voice it to me, but what's going on in here in terms of fear? So it's a lot to unpack. It really is. My approach is not about the patient being subordinate
Mm-hmm.
and not saying anything. My approach is about shared decision making, about trying to equal the power dynamics in this therapeutic relationship. So my patient feels like it's relevant and appropriate for them to tell me what they're feeling and not feeling. And to me, that's what improves safety. It diminishes risk if the patient is willing to actually open their mouth and tell me what they're feeling.
I think that's great. So you've highlighted something on scope of practice, and also there is something like we have to work hand in hand. You have to have your conversation with the treating physician or speech language pathologist as you move forward while using manual therapy. That's a great point.
Yeah.
So, if you're looking at application of manual therapy to voice and swallowing disorder, so how does manual therapy help swallowing difficulties? Could you highlight on that?
Absolutely. Can I just go back a few first for two things?
Yes,
Um
yes.
I want to share with the group a video, and here it popped up in your
Mm-hmm.
feed. Don't watch it now, watch it later, else you won't be able to pay attention to me. But it was made at a class I recently taught last month in Edinburgh, Scotland. And it was a voice professional. He was a speech pathologist working on his PhD, um, who was well versed in a lot of voice exercises. Right, the concept of an exercise is an exercise solely to build strength, build awareness, etc. That's sort of some interesting side conversation I often get into because often in the physical therapy field, exercise is to make you stronger, but exercise has so many different benefits besides being stronger. But in the last 2 or 3 years, Preetie, we've modified the work that I teach during seminars to include exercise while we're doing manual therapy, sometimes simultaneously. And
Mm-hmm.
the video shows a fellow who we were working on some resisted tongue work, all right, for various issues. And I don't remember what he said his issues were. He was very well versed in a lot of the tongue exercises that you might prescribe to somebody do this, do that, that sort of thing. But he was comparing that with what happens when you have manual input in there. Manual resistance, not just to provide the resistance, so that, for instance, if I'm working on tongue elevation, It's not just to elevate the tongue, it's to improve, for instance, passage of food for swallowing. It's improve the fine motor control, right? When I feel a tongue, I press the tongue down and I ask the person to lift their tongue against me. I can feel what parts of the tongue are active, right? And if it's all point or the tip of the tongue, I simply give it a tap and I tap the back of the tongue. And what's so neat is that little motor sensory input almost immediately turns into a different motor output. And that's the stuff we're just beginning to really explore in the class. It's basically an active learning lab when I teach it, because I'm learning a lot from you, the people taking my classes, and then we roll it back into the course curriculum. But I think this blending of exercise and stretching is a real, it's not often associated with manual therapy. And that video link there is just an opportunity for this person, this speech pathologist, to give his opinion, compare and contrast traditional exercise for voice or tongue and some of these manual resistive type things. Not that it's better, but it's different. All right. And before we jump ahead, can I just address that question that came up in the
Sure,
chat from Johanna?
sure,
Yep.
sure.
Joanna, I am not at all familiar with Clark's neuromuscular stimulation paper. If you might be so kind as to drop the reference in the chat, that would be great. Is it based on it? Oh my gosh, manual therapy is based on probably over centuries of historic precedents. Most of those precedents were built on the thought that there's something wrong out here in the periphery, right? Whether it's a trigger point or a scar or a spasm, et cetera. And then the clinician is trained to be able to skillfully get rid of that. That's the story, unfortunately, that still continues in education today. And unfortunately, a lot of my patients walk in the door with that understanding, with that belief. And I try to softly sort of shepherd them into, well, that's historically what's been said, that there's a problem right here in the masseter. But what set that problem in place? Is it the muscle on its own deciding, I'm going to go into spasm? Or are there autonomic triggers happening? Past issues in terms of trauma, et cetera. An overloaded central nervous system. What is the root of that muscle spasm, right? And I think when you look at some of those historical papers, sure, you'll see elements that seem to emanate from that work, including my old field, which was myofascial release. But what I love to say, and I love to annoy the heck out of people when they come in to say, okay, we need to fix that muscle spasm. And I'll say, okay, can you selectively and singularly affect the masseter? Can you do that? And I respond by saying, no, you can't, not unless you have a scalpel. Because as soon as we work through a person's skin, you're highlighting a whole nother potential mechanism up to the brain. When we do this to quote unquote break up the masseter, are we having the effect locally? Sure, but we're also having a central effect. And those central effects are what Kolb, Kolb, which is in the references as well, talks about when it comes to manual therapy education. He basically puts out what I'm saying right here. We know so much. Why do we keep dumbing it down and simplifying it to a tissue-based problem? All right, now I am so sorry for being rude and interrupting you like that. But okay, thank you. I will look at that. Thank you very much. I got the reference that you just sent along, Joanna. I appreciate that. Now you asked me something about
Application of manual therapy in swallowing disorders.
Got it. Okay, so I'm going to be looking at a little bit of if we're talking about swallowing disorders when it comes to upper phrase, pharyngeal phase, you certainly need to worry about mouth opening. Can the patient get sufficient mouth opening? We've got a nice paper by Macmillan. All of these are referenced in your sheet there, where they found significant gains in mouth opening from the use of manual therapy versus some of the device-driven stretchers, like I'm sorry, I just totally lost the name of those tools that you use to help open the jaw, the Therabite, et cetera. All right. What I think is really lovely about Macmillan's paper, and if you read it, they talk about the intervention was applied over the course of a number of sessions. But what I really appreciate about that paper, is they found that the greatest percentage of change from post head neck cancer trismus, the greatest percentage of change came from the first session. Now, for somebody just starting out in this work, what a great incentive to know that on that first session, you have the potential to give that patient the greatest gains. And then what about on the patient's part? From one intervention, they can begin to feel demonstrable changes. I think that's pretty interesting stuff. Um, I'm looking at some studies now that are, again, they're all in your paper. There, Christina Kang is a speech pathologist from the United States. Now she's known as Christina Rosso. She's done a number of papers and work looking at the comparison with muscle tension dysphonia and muscle tension dysphagia, right? And allowing that bridge to be not a totally separate one, but seeing overlap. And Christina, I've met Christina early on when I was teaching this. She took my class early on and it rolls some of this work into the more general, type of work that you all do. Manual therapy should never, ever, in my mind, be viewed as a standalone technique. It's best embedded with all the other interventions you do. How you come, the formula you choose to do that, that's up to you. Some speech pathologists will say, well, this session, we're going to spend more time on the manual. Next session, we'll do more of that. Everyone does it differently. And it's not better. It's truly just another tool for you to reach for. We talked about the Krishna study with radiation, but in terms of the effects on the fibrosis, that's certainly an important one. We've got a couple studies by Burke, Lewin, and DiPietro on dysphagia, et cetera. There is less quality evidence in the literature, both in and out of the speech pathology field, for manual therapy with dysphagia as compared to manual therapy with dysphonia. And I'm putting that like right out right now. It's coming. In fact, this afternoon, it's early in the morning here. This afternoon, I have a Zoom meeting with one of my teaching assistants. She's PhD from Stanford in California, and she's putting together a study on swallowing along the lines of the CTAR, right? The CTAR for improving swallowing as an exercise. And we use a different type of exercise that's stretch driven to give laryngeal resistance, anchoring the larynx, et cetera. So, between hopefully this study that might be out in the next year or two, and some other studies that some people are working on, I'm really hoping for more. I'm not a researcher. I don't have that sort of resources, et cetera. But I love working with others who have that interest in saying, what if we tried it with this?
Thank you for highlighting that. It's about how we look at it and how do we work with different techniques and utilize the manual therapy techniques so that it can improve patients' swallowing ability. Thank you for
Exactly.
highlighting its applicability for swallowing disorder. As we
Yeah.
move, I would like to know there are voice professionals like singers and teachers. They put a lot of strain on their voice. So how can manual therapy be integrated in their vocal health routine? If you can highlight on this.
Yeah. Well, you've sort of got two separate parts of that. You've got the role that we can play, right?
Mm-hmm.
The role that we can play in terms of intervention, and whether it's my kind of intervention or other voice related interventions, vocal hygiene, vocal rest, all of those things. And certainly this work has been shown over the last 12 years of me teaching it to be well incorporated into the vocal performers type of a role. I know a number of therapists, clinicians who are literally traveling with, elite level artists, and not just doing this work, but they've added it to the work that they do when a person is having vocal strain or injury issues, adding elements of it to the warm up, the cool down, et cetera. And then you've got the other leg of it. And by the way, there is literature out there on the use of manual therapy as somewhat of a preventative measure. Prevention is a difficult one to measure unless you do, two groups over the course of time. And there's some studies out of the Scandinavian countries that were done on teachers at the beginning of a semester versus the last end of a semester, teaching them self-care skills from a manual therapy perspective versus not, and showed some nice changes or less of a problem at the end of a school year. There's also some studies on singers. I have a more complete reference list on my website if anybody is interested. All right. Then you've got the other piece of teaching your client or patient this. In this class that I teach now, I get licensed professionals, and I use the word license in the United States. A physical therapist, a speech pathologist was considered licensed. In the United States, a voice coach is not considered a licensed professional. And it ethically, legally, and in the mind of others is not supposed to be doing this work. I have issues with that, but that's a whole other topic. But they certainly can teach their client, their student, or our patients self work, right? Some of the stretches that we teach in the class are just so simple, and they're so easy to translate over to a patient to make us so we're not necessary, right? I would rather make it that you only need to see me once or twice. If you can maintain or continue to improve, I mean, I think that's a win for all of our systems instead of making you a lifelong patient of mine. All right. So you've got elements both in terms of the intervention that we can give, as well as tools for self care, adding it to warm up, adding it to cool down. You know, if you're, I sort of fringe on the voice field when it comes to voice teaching, voice coaches, and man, oh man, talk about a unbelievably wide range of beliefs and views. What's the proper posture? What's the proper way to hold your tongue? What's the proper way to breathe? And it seems like everybody's got a different story. And maybe that makes sense because if they didn't have a different story, there'd be no need to learn from another person. Is there a proper way to breathe? Not quite sure. I'm 65. I must have lucked on it because I'm still alive. I'm breathing okay. And I know that sounds sarcastic and cynical, but I think sometimes the views that we translate to patients are part of the placebo that we're offering to them. I am an expert. You came to me for advice. Here's something you might want to try. And boy, when you have those credentials after your name, that carries a lot of weight. I like to keep my boundaries that yes, I am an expert, but here's something for you to try. It may not work, and if it doesn't work, we'll try something else instead of saying, here's what you must do.
That's great. I was trying to highlight because there are a lot of lower middle income countries where we may not have everybody who is certified and things like that. So I was looking for, is there any way that some of the caregiver or some of the participants who are cognitively good, they can take over some functions, means some of the goals from the clinicians so that it can be effective and more good, a lot of outcomes can be better. So that's what I was
Yes,
looking at.
you are absolutely spot on, and that's the way I treat patients here. Whether it's the patient doing the self stretching, a significant other, right, caregiver. I warn people. I warn my patients when a patient comes in, and maybe I'm working with a male, and he says, "You know what? Do you mind if my wife comes in and you can teach her how to do this?" I say, "Absolutely. I have no problem with it." But I also warn them. I warn them that sometimes it doesn't work. Sometimes when I ask, especially when it comes to a significant other, you're asking for that significant other to change their social role in the relationship from a partner to a therapist. Sometimes it works, sometimes it doesn't. I just sort of warn them. I don't want to say don't try it, but if it explodes in your face and ends up in an argument, just don't get too upset, right? It's hard to have people change roles in relationships.
That's great. I think it's very much important for us to know how, when, and where can we transfer functions and have to use
Yeah,
it with caution.
yeah,
So, yeah. Okay, so you've spoken a lot about sensory stimulation. So, even it comes to neurological dysphagia or neurogenic dysphagia, sensory motor aspects is very, very important, and that's how we work with the patients with dysphagia. So, what do you think? How can manual therapy play a role in improving the functions in neurological dysphagia or neurogenic dysphagia?
yeah. I'll be blunt with you, Preetie. I'm kind of working on some of these narratives myself right now. Um, from an observation standpoint, I've seen it before I was working with your population and you as therapists. And I'm hearing it back from clinicians now, feedback from other from people who've taken the class. Gee, I tried it with a patient with, Parkinson's, and we had this effect. And how well does the literature explain those effects? Often not very well. In terms of, I'm gonna artificially break down research studies into two categories, and I know that's just grossly simplifying it, but we have outcome-based studies that said when we applied this work to somebody with Parkinsonian dysarthria, using this mindset, it was effective. Right now, those are necessary. We work from those papers. But when you really try to unpack the mechanism of action that underlies that intervention, that's where I think most published research really fail badly. Because in my experience, when I read a manual therapy paper, I recognize that reaching back into the past to grab a fact, put a reference to say the reason the person with Parkinson's is having dysarthria is fill in the blank, right? And when we did this, that changed. I'm we still need those outcome-based studies, but the mechanisms, that's the complexities of this work. And unfortunately, it's just grossly underserved. That's the point of this paper that I published, is not that it is the answer for everything, but every interaction you and I do is a lot more complex than the simple story we tell. Think about exercise, right? Is the reason a person can talk better, swallow more efficiently and more safely after exercise is because they're stronger? Probably not. There's so much more, right? The understanding of the feeling of danger, the feeling of less danger, right? Sensory awareness, how to overcome that motorically. It's incredibly complex, but that's what really goes unanswered in the majority of the literature. I think that should be on the onus of journal publishers to say you got to do better than that. But anyway, that's very Pollyanna to think in those directions, but definitely from a neuroset perspective. Let me go back to that Parkinsonian dysarthria paper. It is, I don't think it's on my list here, but if anybody's interested, I can get you a copy of this. It was done by a researcher in 2017 by the last name of Ateras, Ateras. Ateras was looking at the effects with Parkinsonian dysarthria on a specific kind of manual therapy that they call neurodynamic technique, which is the perspective that every nerve in the body is covered and surrounded by a tunnel, a connective tissue tunnel. Neurodynamic theory speculates that we get pain, we get motor impairment, we get all sorts of issues if there is basically a kink in that tunnel. If the nerve can't express freely, then you might get a sensory or a motor or a pain response, etc. I'm grossly simplifying it here because that explanation has evolved considerably. But what they looked at Parkinsonian dysarthria with, they mapped out the facial nerves and how to address them literally from a manual therapy perspective. And I love that paper because it's one of the few papers that I have access to that a clinician could actually learn from. How many times have you read a study that says, wow, there's some great outcomes for this disorder by using that, but you learn nothing on how to do it? I think that's useless education. That's useless research if it doesn't advance us, the ability to translate that research into practice. When I see a study like Ateras, is they don't give the entire protocol in photo form, et cetera, but they give some real down to earth type of explanations, not only on the theory of what you're doing, but how to access the nerve and photographs of them accessing some of that nerves. And to me, that's how manual therapy and all research should be written. So, I mean, let's face it, we're supposed to be able to learn and then translate that into practice. But if it doesn't tell you how you do it, what good is it?
Definitely. I think I agree with this, and I think most of us whom I know and the participants agree with it, because a clinician is somebody who translates everything that is means that we are looking for in terms of outcomes, and then comes research. So if we should be able to translate or give away the information so that everybody is able to access and try it. So that's something which is great. So I think you
Right.
mentioned about facial nerve. So I remember one of the participants asking how manual therapy can improve functions in patients with facial palsy. If you can talk something about that.
Yeah, that's where we get into some of the gray zone. I'm going to be honest, Preetie, because there's not a ton of good evidence, really good evidence, when it comes to Bell's palsy, facial nerve, et cetera, et cetera. Um, if we went outside this region that we're talking about here, I might be able to pull out some papers on that. Um, what's the lowest form of evidence? Antidotes, right? We're not supposed to work from antidotes, but yet, how can you ignore it? Right? And I'm not advocating for saying antidote is evidence. But okay, so as a part of this class that I teach, that I'll be teaching in your country in November, we run a Facebook group for people who've completed the class. It's a private group where we upload videos from every class so they can watch videos from all the classes that have been done in the last couple of years, et cetera. But we also get a lot of conversation. And what I love to see is people taking the initiative to say, you know what, I have no idea if this will help with Bell's palsy. But when I tried it, the patient reported this. We saw this change. Um, should that be how I ground my approach? No. I ground it in real evidence. But on the other hand, I also can't ignore those anecdotes, both here in my clinic as well as with people's experiences with patients. And I didn't answer your question in a very academic way, but I try and be as transparent as possible. Hopefully, over the years, they might come up with more evidence for why is it that when we give input to an area, that sensory signal goes up here and somehow results in a motor change. You know, it sounds so simple, but yet we don't have good evidence for the full mechanism for that yet.
Yeah. I think
Yep.
any researchers begin with case studies and they learn from case studies, and then they
Mhm.
go to a bigger study looking at the methodology or the intervention they've done. So I think a small case study would definitely take some researcher forward with their ideas and they work on it. So I'm sure in the coming years we are going to see a lot of research on that too, probably.
Yeah, and I would love to be a spark in your country too, to get people thinking along different lines. As long as people are stuck in the box when it comes to manual therapy of thinking that it's all about what I'm doing to this tissue right here, we're not going to advance anything.
Not good.
But once we can realize that touch is simply another form of communication, I think that's when the door will open. Can I just respond to Prasanna's
Sure,
question or
sure.
comment there? The video, Prasanna, I'm guessing that you're referring to is me doing retrolaryngeal, behind the larynx work, behind the strap muscles, etc. And yeah, it's something we teach in the introductory class with the right kind of precautions because we're in the area of the carotid artery, etc. I look back on an old study done by Murray Morrison in 1997, who was looking at pattern recognition and muscle misuse disorders. That's the title of the paper. They were looking at certain patterns when someone has muscle tension dysphonia, whether it was an auditory one or other things, basically telling the therapist that if your patient demonstrates this, you might want to check this, kind of like a little checklist type of thing. But in that paper, Morrison talked about if the inferior constrictor muscles are held too tightly, right? If there's too much tension between the thyroid cartilage, the larynx, and the spine itself, pulling the essentially pulling the larynx tight against the spine, you're going to get a diminished elevation in laryngeal excursion, whether that's for voice or swallowing. And in that paper, Morrison talked about the benefit when it comes to some of those issues of working this area right in here. Morrison called it the gutter, the laryngeal gutter. Now, I'm not sure in India whether it translates the same, but in the United States, a gutter is that thing on the end of your roof that catches the water, or it's the thing on the road, right? And this does resemble sort of a gutter. He was writing that paper from a laryngeal manipulation perspective, that if there's too much tension holding the larynx back, then you get in there and you do laryngeal manipulation, which certainly is effective. In the class that I teach, we do laryngeal manipulation, but we also do more gentle, more sustained ways, because I think it's the sustained aspect that gives a patient time to reflect on what they're feeling here, up here in their head, right? But when it comes to that, we are affecting certainly the inferior constrictor muscles, but we're also affecting autonomics, central factors, etc. So that's the kind of thing that, I've got videos out there and other people have videos out there talking about using this retrolaryngeal work. And Prasanna, I think that's what you're talking about. I'll just give me one more moment here. We also have quite a few videos that we've done at seminars where we'll have a FEES device and our volunteer is being scoped. So we've got the images from the FEES, and then we're doing manual therapy while the FEES is being done. And then we take those two videos, right, from the FEES as well as somebody recording outside of what I'm doing, and we time match them so that you can see when we do certain things to both the larynx as well as the retrolaryngeal area, you can see the effect internally. And it doesn't necessarily prove anything, but it does show that when we move our fingers retrolaryngally, you will see an effect on the arytenoids, on the vocal folds, etc. And to me, that's cool in a way that maybe that could open up some doors for research. And Prasanna, I think I got all of your questions there. Good. Okay, great. Feel and express. Okay, I'm just going to run on with this question here too. The person who can't communicate. That's a really great question because, I mean, obviously that's a part of your field. What I look for though, can they give me any feedback? And it might be things that we're interpreting, facial feedback, body language. Maybe it's interpreted feedback from a caregiver, right? Can they give me any feedback whatsoever? And if so, that's what I work from. Again, spending years in pediatrics, I did home care with dementia patients, etc. You're not getting that feedback that we all hope for, right? But can this person give me some feedback? Do I trust them to give me feedback? Because the person who walks in my clinic fully verbal, fully cognitively intact, fully sensory intact, that doesn't mean they're going to be a good communicator either. They may not tell me things because they think it has to hurt. Go ahead, I can take this. I tell a story in my classes that it's a little troubling, but I'm going to tell it right now. And it's one that made me rethink how I view somebody when they walk in my room. I had a woman come in to see me for hip pain. I don't teach hip treatment during the voice and swallowing class, obviously, but the take home was she explained her problem to me. We started treating. I said, if there's anything that's too much, please tell me. And she said, I will. So we were starting to work in the hip region, and I'm doing my stretching, of relatively gentle stretching. And as I was doing it, I was watching her go into a big grimace of pain, but she never said anything. And I said to her, is that too much? And she said, just don't do any more than that. I said, okay, I want to be more gentle this time. Please tell me if it starts to become painful. She said, okay. And I started again. This time I was more gentle, but I was watching her face. And again, she was going into a grimace of pain, but she never opened her mouth. This cycle repeated itself and repeated itself to the point where I was literally just putting my hands on her upper leg and lower abdomen to treat that area. And her face registered pain, but she never spoke a word to me. And it wasn't until a few sessions later, and I don't remember the context of why she said it, but in her life as a child and as an adult, it was never safe to say no or stop to a man. And I was asking her, she was a teacher, she was intelligent, she could speak, all those things. I was in essence asking her something to do something that she was incapable of. Now that's just, it is a sad, a horrible story of, what happens to people, etc. But it was a life lesson for me. Don't make an assumption just because they nod their head and say, yeah, I'll tell you. Okay.
I think that's a good example, and we'll have to watch out for everything that we do with the patients. So I think since you
Absolutely.
mentioned about cognitive impairment, I'm going to bring up a question on that because can manual therapy be effective? You answered it, but still, I'm just going to cover that question. So, can
Mhm.
manual therapy be effective in patients with cognitive impairment or reduced cognition? So,
The answer is maybe.
maybe. So, do you have to
But I'm
modify?
See, that answer is the same for any patient of
Yes.
whatever cognitive or communicative level. The answer is maybe. We know in all our interventions, when it's supposed to work, sometimes it doesn't seem to, right? How do we explain that? Boy, that's complex. When it comes to the cognitive impairment, I try and speak as simplistically as possible. If at some level there's a level of understanding, even if the person doesn't seem capable of processing and responding to my question, I still ask the question, right? I pose the question to that person just as I would somebody who cognitively can understand. And I still ask the question, does this feel safe? Questions like that. I monitor for verbal reactions and nonverbal reactions. Respond to what the caregiver might be perceiving. That's just something I learned early on. And can it work? Absolutely. If we view it as part of a grander picture of what we're doing with the patient. I still, even though most of my patients right now are, fully ambulatory, fully cognitively intact, I still get developmentally delayed children and adults, and I still get head injuries adult into my practice here, where you're dealing with those cognitive variations. And I mean, that's the challenge of our work, right? To translate what we learn in the ideal to our real population. I want to just kick off a topic here for a second. Um, that the concept of when somebody comes to my class, they think they're going to learn some very specific manual therapy, which they will. But what I really hope that they leave my class with is an understanding of shared decision making, on how diminishing our sense of expertise so that we elevate the expertise of a person, of a patient, to be relative equals. That's really one of my goals in this class. And I started incorporating that in the very late 90s and early 2000s. And during the COVID shutdown in the United States, I had a lot of chance to reflect. I totally revamped my curriculum, but I also was invited to write a book. I was invited to write the paper. And I embarked on a master's program to take my entire curriculum and put it into an academic framework. And when I was looking at shared decision making, I saw a lot of the historical building blocks for it, as well as how it's mentioned in the literature in speech pathology and physical therapy. But it wasn't until I gave a lecture. I was invited by the University of Pittsburgh ENT grant to do a grand rounds talk one month, and I was talking about all the stuff we're talking about here, how we can use manual therapy for voice disorders, shared decision making, et cetera. And one of the professors there at the University of Pittsburgh, SLP, interrupted me or stopped me for a second, asking me whether I had heard about any of her work. Her name is Leah Halal, and Leah has written fairly extensively on a concept called metatherapy. Metatherapy, simplistically, the way she writes about it in the first couple of papers, a clinician in their training learns the techniques, right? Learns the techniques that they'll be using for the rest of their career. But when they get out into clinic, they apply that technique for a voice disorder, but they don't get the outcomes that somebody who's been doing that same technique for 10 years gets. And what Leah in these papers is she looks at that difference. What is it about the new clinician applying a technique and the seasoned, experienced clinician? The technique is identical. It really is. But what creates the difference is the context that the clinician with experience applies it in, how they envelop it or wrap it. And what Leah saw in her concept of the meta that surrounds the therapy was, in my approach, the meta is the shared decision making. The technique is what we're doing here to the pterygoids or here to the masseter, right? But it's the context that we apply it in that, to me, almost has more influence than the technique itself. Because I want to make sure that it's relevant and relatable to you, Preetie, not just because the study says that this is good for mouth opening, right? And I think that when I can ground my work in something that's internal to your dialogue, metatherapy being in the work of a speech pathologist, writing about how we need to approach, mentoring new clinicians, et cetera. To me, that brings it even more home in terms of this is relevant work for the speech pathologist.
Thank you for highlighting that intervention is tailor-made, which we all look forward to. So it's about learning and applying, or learning, modifying, and applying it based on patient need. I think that's
Exactly.
something very much needed. So your manual therapy, it's does it work equally well with children and older adults, or do you have any key differences in a way how it is applied?
Well, potentially, I don't think there's a difference. Children, adults, there's definitely different in application. Having spent my first 5 or 6 years in early intervention, birth to five, I can't get that 3-year-old to lay on my treatment table for an hour like I might get my adult. So I learned the hard way because that's when I started learning some of this work. When I was crawling around on the floor with these toddlers and whatever, um, trying to figure out how can I do this work. One of the biggest challenges for me with that was I was taught that I have to spend a minimum amount of time. And back then it was basically 2 minutes. If I'm not holding a stretch for 2 minutes, then it wasn't effective. And those kids were never giving me 2 minutes. So I gave them what they would give me. And immediately, early on, back in the early 90s, they immediately saw flaws in the way the model was taught to me. Because I was taught, well, you have to hold it for this long or it won't help. But I saw that sometimes even short interventions did phenomenal things. And maybe that started this skeptical mindset that got me in so much trouble in the early 2000s with my past, the model that I used to work with. All right. But when it comes to pediatrics, I still see kids. Can I tell you a quick story? I love stories. Um,
Yeah.
um, a, a mother brought her child into me with some feeding disorders. The boy was 5 years old. He had pervasive developmentally delays. He was nonverbal, non-ambulatory, um, required total care. All right. He had a lot of gross motor issues that were being addressed by PT in school, but he also had some feeding issues that were being addressed by the speech pathologist. He basically pooled food, right? And it took mom, who was a pediatric occupational therapist, it took her on average 40 minutes, 40 to 45 minutes to feed him. The people at school, same kind of problem. It just took a long time. And she wanted to know, could I help him? And it's like, I don't know. I have no idea. Let's give it a try. So she brought him in. I came in the stroller. He was a reacher. He was a rider. He was a grabber. And I'm thinking, okay, how are we going to work this? He wouldn't lay on my table. So we kept him in his therapeutic stroller. We strapped him in. I leaned him back. And I put my hands on his face. Based on what mom said, I really wanted to be able to engage his tongue. But honestly, Preetie, I didn't trust him not to bite me. Okay. So I kept that safety in mind. And I put my hands on his face. And he immediately reached up and took my hands off his face. And I'm ready to stop the session right away because at first it was like, I can't work with this child because he won't let me do what I do. Mom saw the problem. Mom said, sometimes when I sing to him, that distracts him. And I put my hands and she started singing, and it did. It distracted him. I always work when I'm working and sitting. I work behind a patient and I work in front of a mirror. So I could see his eyes being drawn to mom. But then after a certain period of time, it was like his attention came back to me and he reached up and he pulled my hands off. Okay. So I have another dilemma. All right. How do I work this in terms of can I tell if something is meaningful to him? So I started to notice nuances. Sometimes his eyes came back to me and he immediately reached up and took my hands off. Other times I saw his attention coming back to me, but he didn't immediately pull his hands off me. I was doing a lot of interpretation as well as mom, but I speculated maybe those times when he's coming back but not reaching, I did something that caught his attention, caught his interest, right? And we worked in that way. Sometimes him reaching up and pulling me off right away, and sometimes letting me just work for a while and watching his eyes do what eyes do when something interesting is happening, right? Um, my kid sessions are short, typically 25 minutes long, based on tolerance. And we finish the session, and I'm thinking to myself, and I have a lot of self doubt. I'm human like the rest of us. I'm wondering, did I just waste their time and money? Right. So they came back in about 3 weeks. And I asked mom, so tell me about what happened since the last session. She said, it's been really interesting. I did a little bit of what you taught me, right? I did a little bit of the tongue work because she said she trusted her son not to bite me. And she said, and we're down to about 30 minutes per feeding. I was like, wow, that's pretty cool. Considering I wasn't sure we did anything. At least, how did I modify his tissue in these short periods of time? And that was just more information to me that maybe it isn't about changing that tissue. Maybe it's about changing that sensory motor loop, right? We worked, I think, a total of 5 times over a year and a half, a real considerable time frame. where other things could come into play besides just what we were doing. But this boy plateaued at about 20 minutes, where and mom was exceedingly happy at 20 minutes. Affect change on the face was certainly there. I still look back at that and ask myself, what is it that changed, right? Was it the tissue, or was it that boy's ability to maybe change the map up here on what happens when someone touches, what happens when I eat? I still don't know what it was that we did that helped him, but something helped him. All right. So pediatrics, geriatrics, sports, vocal athletes, to me, it's all the same work.
That's great. I think it's everybody's story with children and adult or the geriatrics. It's very interesting and how we develop the interest and how we work through. That's great. So I'm going
Yeah.
to take one question from the chat. Joanna is asking, based on motor learning principle, is there any dosage, intensity, or duration that you consider while doing manual therapy?
Yeah, there's very poor evidence out there for dosing. For dosing within the speech pathology field or outside the basically most of the papers that you might find and read were based on historical narratives. I learned the historical narrative that it has to be a minimum of 120 seconds. That same group that I trained with says no, now it has to be a stretch must be held for 5 minutes. Um, but we've already proven that wrong. When it comes to speech pathology papers, that 2019 study by Chris Shunis that I mentioned earlier, they take a stab at dosage. And the stab at dosage is basically feedback from speech pathologists. And there's a uniform observation that people who are having voice disorders and use manual therapy, that they need to be seen less frequent than people with head neck cancer related issues. That same group, led by I'm trying to remember the lead author, and I can't remember. Chris Shunis is in it. It's a newer paper from I think last year, where they took a look at all the studies out there for manual therapy for dysphagia, but they found a lack of consistency in the protocols. Okay, and they talked about the need for a protocol if we're going to transition this into trying to decide on dosing, whether it's how long a session should be, how frequent should be, et cetera. And it was funny, Preetie, because through my entire career, I've said that protocols, they're necessary, but the individual sometimes negates the protocol, or you change the protocol, right? I understand the value of a protocol when it comes to trying to come up with some objective evidence, but what I really dislike is when I see a clinician feeling like that work only applies if you do the protocol exactly how it was given, right? So I do understand the need for protocols when it comes to dysphagia work. And I'm certainly willing to be out there helping develop a protocol, but I'm going to put a massive disclaimer out there that once you get into practice, don't feel like you must follow the protocol 5 minutes here, 5 minutes there. All right. That doesn't help you much. Typically, if you have inpatient population, you have a lot easier access to more frequent intervention. When you're dealing with outpatient, what do you do if the study says you have to see that person 5 days a week and you can't see patients 5 days a week? Do you just throw up your hands and say it's no good? Or do you modify it and say, okay, I can only see you once a week. Let's see if this helps. I'm probably a little too flexible when it comes to those sorts of things. And I irritate more evidence-driven clinicians. I believe the evidence is necessary, but I think if we get locked into a protocol, we're going to miss opportunities to meet a person where they're at.
And that's a great point. Yes, we do believe at the moment we are all looking at motor learning principles, but we are also looking at how well a patient can perform one or two intervention method that we have picked for them for different goals.
Right.
So, Prasanna asks, internal lymphedema is thought to be most difficult to treat and often gets on the list of wait and watch based on the corticosteroid medications given. Any thought on use of manual therapy for them?
Yeah. Early on, when I started teaching speech pathologists, I had a speech pathologist take my course. She went back to her hospital to try and use some of it, but she was overruled by the trained therapist who said you can't do manual therapy until the lymph is under control. And I didn't have an answer on how to get past that. I think a lot of that goes back into historical ways manual therapy was applied with more aggressive or some manual therapy. I'm going to sort of demonstrate it on myself, was where they would come in with a finger and do dragging to try and break things up. And when it comes to patient with some severe lymphedema issues, I wouldn't want to be applying that sort of work at all. I, I don't like it applied, period, not just with lymphedema. I don't like those aggressive kind of works. I understand they're helpful. I understand some people do, but I don't like them. So if we can sort of take a look at what manual therapy might be and not is, right? The view that manual therapy is aggressive keeps people, puts a wall up between, no, we should be doing that with somebody with lymphedema. But when you see manual therapy applied as a gentle intervention, a sustained sort of stretch that in some ways resembles lymphedema therapy, I think you can see an opening where the two can be applied, maybe simultaneously or close together. If you're if you're on Instagram, follow Brooke McGivern. I don't know whether what her actual handle is on Instagram, but Brooke is a speech pathologist who is one of the most altruistic people that I know in terms of giving with no expectation in return. All right, whether it comes to lymphedema work, whether it comes to manual therapy work, or whether it comes to the wider view, right? And I think Brooke is presenting remotely, right, for you while I'm going to be there live. I think we talked about this. Brooke has done a lot of she's done a lot of those scoping videos like I've done, where they're doing the fees plus doing manual therapy. But she has some really beautiful takes on how to weave in manual therapy with lymphedema work as well. All right. So I would defer to my friend and colleague Brooke on some of those issues. But if you're hearing people say no, you shouldn't use manual therapy when someone has lymphedema, you need to probe what does manual therapy mean to you, and maybe demonstrate to them. A lot of my work is unbelievably light. It's simply touching somebody, and that can start a cycle of change in and of itself. And if they're coming from that don't do manual therapy from the old views, let them know what manual therapy can be.
That's great. I
Yes,
think we're
she.
looking
Yep.
forward to have Dr.
Sorry.
Brooks also. Yeah.
Yep. Yep. Got it.
Yeah. Yeah. So next question I would want to ask after this, you already highlighted it. Manual therapy, can it be considered as a standalone treatment, or would you want to use it with complement? Means how it would complement with other approaches that we're using. So I think you
Yeah.
partially answered that. So if you can.
Yeah. Well, historically, manual therapy has often been a standalone, right? Think of massage. Massage is a form of manual therapy. The person comes in, they lay on the table. An hour later, you're done. You leave, right? That can have benefit. I learned myofascial release in the early form of this work as more of a passive intervention. Although they never said the patient shouldn't participate, shouldn't, talk about it. A lot of times it is done in silence, that sort of mystical kind of let's just do this work and you can go deep. I want to bring the patient's lived experience into the manual therapy setting, and that could be through your existing interventions. To me, it's often, okay, well, every time I turn my head to the right, it hurts so much I don't want to look over my shoulder in the car. Okay, so let's do some manual therapy while you're looking over. Tell me what you feel. Does it feel safer? Does it feel more effective, right? We could build in exercise with that, or strengthening, etc. So the answer is, as you already alluded to, it can be standalone, but I don't think the patient is best served when it is standalone. Incorporate it, blend it, whether it's we're going to do manual therapy now, then we're going to do this, or the way we talk about it in the seminars is you're almost doing exercise and cognitive behavioral work while we've got the manual therapy stretch going on.
There are some thoughts like oromotor sensory work done might benefit incorporating manual therapy techniques as an adjunct
Exactly.
method for pediatric feeding related issues. Any thoughts on that?
Absolutely. I'm an expert only in what I know, right? Early on, we did a lot of feeding when I was working in institutional settings where basically all the professions helped with feeding. But I know there's a lot of skills that the SLP and the OT, at least in the United States, bring to feeding, that sensory motor aspect of it, the awareness. And I don't know all that. I just say, what will touch add to that sense of awareness? Whether it's the ability to move the tongue, the ability to control the bolus, the ability to elevate and retract for swallowing, right? Will this tongue work aid with that? That's what we're looking for. And I know I kind of avoided your question, or sort of went around it a bit, but again, I'm very transparent in saying what I know and don't know. I know manual therapy. I know enough about this work to say it might be really helpful for you.
Definitely. I think it's about us how we apply the concept of manual therapy to different patients or disorders we have and look what fits best for
Yeah,
them and tailor make it. That's great.
yeah.
So
One of the earliest things I learned about too when I was learning about this work is, um, when I learned this work, it was said that a person needs to dive deep into the emotions of their problem, in order to truly heal. Now, I don't like narratives like that because a lot of it almost imposes on the patient that if you don't dig emotionally, you're never going to get through this. But there was a paper published in 2022. It's on the reference list by McParlin, and the title of the paper is Therapeutic Alliance as Active Inference, the Role of Therapeutic Touch and Synchrony. When I spent this COVID time working on my book, working on my master's, working on the paper, I moved beyond just the PT literature and the SLP literature, and I moved into the psychological literature, the behavioral literature. And when it comes to touch, basically manual therapy is under the umbrella of touch. There's so much evidence for the effects of touch, the affective nature of touch, of safe, appropriately applied touch when it comes to allowing a person a connection to their lived experience. What I love about that paper by McParlin is they talk about touch's ability to connect a person to the prior experiences, to their prior life experiences, both the positive aspects of touch and possibly the negative, but also touch having potentially the ability to bring somebody into a connection with the circumstances that this problem originated from. And I'm trying to work with an entire human being, not just their masseter. So if I can apply a touch in a way that brings them into connection with a past experience, I can ask them, does this feel safe? Does it feel like it might be helpful for this problem? And they're answering the question not only from the present moment of what I'm doing right here, but they're also referencing the past, their priors when it comes to that. And I'm not a psychotherapist. I don't pretend to be one. But looking at the literature with touch when it comes to psychology, I think is just as important as looking at it. Will it help a swallowing disorder? That sort of thing. Understanding the macro of touch and not just the micro of touch, I think is so necessary for the work that I teach as well as the work that I do.
that's great. So I think we've got a lot of research that you've quoted based on the like effectiveness of manual therapy, which are the disorders related to voice or swallowing disorder that it can benefit. So if we have clinicians who want to add manual therapy to their practice, so what do you suggest? What kind of training or
Mhm.
certification would you recommend them? I think that's
Yeah,
important.
Preetie, it's an interesting question. For decades now, for the decade of teaching this class, I've said to clinicians, you know, tiered training, multi-level training is the norm in my field, in physical therapy and manual therapy, and I'm guessing in speech pathology, where clinicians they start out at the basic introductory class, and then you learn more and more and more. And boy, that's effective. It models our academic training, right? But I do think sometimes people feel like, well, I shouldn't be doing this until I'm really good at it. And while I recognize that, I also think that we get good at things by doing, right? By implementing things right away. As long as we understand the cautions and the precautions, the red flags, etc., and we work from a very safe level of touch and pressure, I think manual therapy is able to be implemented after. Well, I can only speak from my frame of reference, from the type of class that I teach. Um, in the UK and other parts of the world, Jacob Lieberman's approach to laryngeal manual is very well regarded. I actually took Jacob's 2-day class in England in 2019, and he kind of follows a similar protocol, right? We are educated and trained health professionals. I don't know that you need to do an entire master's program just on manual therapy to become proficient at it. Some people feel they need to, or they need to do a lot of practice and more training, and others feel like, no, I got this. I don't want to overly empower someone, but I also don't want to put up walls to say, no, 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 you shouldn't, you need to follow all these steps. I don't know right now that anywhere in the world a certification exists for manual therapy for voice and swallowing disorders. If it does, it's an artificial certification, meaning it's not a governing body saying you need the certification. It's somebody saying, I offer certification. I don't offer certification. You take a class from me. We do mentoring in the class. We do follow-up mentoring on the Facebook group, etc. But you get a certificate from me. Does that qualify you? Those are gray areas, right? What does it take for you to be qualified with other things you learn? Um, I know lots of clinicians feel like we need to be certified. Okay, find a certification, but does it really make you better equipped? That's a good question. Okay. Um, yeah, and I don't mean to be evasive about training certification, but I don't think this requires massive amounts of money and time and commitment to at least start this process of saying, Preetie, when I touch you here, does that feel safe? Does this feel like it might be helpful for that chewing problem, for that voice issue, for whatever it is? Does it feel like you want me to change anything about it? I introduce this work to the clinician in a way that's really simple, right? It's complex work when we look at the mechanisms, but the technique itself does not have to be complex, all right? So, did I totally avoid your question?
Yes, but I would like to tell that I think I'm highlighting more on speech language pathologists. We are already working on oral muscular stimulation. We know about it. It's about levels of training, as you highlighted. I agree with that. So it's
Yeah,
about how do you take these techniques and how do you apply on the different disorders that we have, and how do you
exactly.
want to skill? Means how do you want to level up with different skills that is available, and how do you want to apply it to your patients? I think it's about
Right,
that.
right. One more thing. Are you familiar with the IOP? The tongue,
Yes,
right? The
yes,
tongue measure, yeah,
yes,
tongue strength. And it's often used in a therapeutic setting, right? We're going to use the AOP to
yes.
build strength, which it's nice. But ever since I've got a lot of SLPs who use the AOP, and ever since I taught them some of the tongue strengthening techniques, the manual ones, some of them have modified how they use the AOP. They use it as a pre and a post test. They do a pre-test with the AOP, then they go in and we do some of the manual stretching and the manual resistance, and then they use the AOP as a post test. I'm not saying that's the way it should be done, but I love that ingenuity of clinicians to say, okay, the AOP is a therapeutic device for strengthening, but it's also an assessment tool, combining and blending things that me as a physio outside your field would never have even thought of, but that spontaneous quality that all of us can have to say, okay, I learned it this way. Well, what if we change it up a bit? What if we insert touch, pressure, stretch, all those things? How might that change the outcomes? And that's the kind of entrepreneurship, I'll call it, that I really appreciate in people who take my class that are not just looking, where's it written in the study that we have to do it this way? Where's it written that we can't start modifying this? Right. And that's where I think manual therapy can be a real asset to your existing skill set.
That's true. So I think there's one more question. Can we look at pre and post measurement of SEMG, or is the expectation of change in muscle tone too quick? How do you objectively monitor it, and how many sittings may be ideal to look at this change?
Boy, that's a question. I'm not sure I can answer fully. Um, if the muscle tension or
Surface
tone
in, yeah.
is too quick, that's an interesting one. I'm going to be transparent here. I don't see a lot of those patients here in my clinic. Okay.
Mm-hmm.
Um, I have to work through feedback from speech pathologists, right? Um, if if the muscle change, if the tone changes and the patient develops function, an awareness of that function, I think there's an increased aspect of it will probably stick around if they learn a method to begin to be able to eat more properly, swallow more properly, that sort of thing. And they had that sensory and cognitive awareness to process that. I think that's part of what creates change. The question often comes up, well, what is it that's creating change? Don't we have to repeat this? In some cases, you do, whether it's you repeating it as the clinician or the patient doing the homework to repeat it, to reinforce those new motor skills. But sometimes, if we simply can give that person, I see this in the orofacial malfunctional, right? They try and do cognitive exercises to get the patient to elevate the back of the tongue, to have full contact, right? And they try and try and try, but sometimes you just give them that little stimulus by me tapping the part of the tongue that's not elevating. And they say, oh, you mean that right there? And they instantly have that ability now. Sure, we might need to retrain that a bit or reinforce that. But once they develop the motor awareness on how to overcome that sensory deficit, typically that's something that sticks around without worrying about how many times do we have to repeat it. And that's where people get frustrated by my rather ambiguous approach. I can't tell you how many times you're going to need to see a patient because maybe the first session is enough to start a new motor pattern that they can hold on their own.
That's great. I think we are done with most of the questions. So
Okay.
if there is anybody from the participants would want to interact, ask some questions, you can unmute yourself or type in your questions.
Yeah. I personally, because of my hearing impairment, would prefer them being typed if possible. All right. But I know, and I'm just kind of peeking over on the Facebook Live. If you're watching on Facebook Live, I'm going to come over later today. It might be your night and answer the questions that you've asked. And if there's any more, you can certainly put them on the Facebook live chat as well. All right. Okay. So nobody's coming up in questions. I want to tell you, Preetie, first of all, thank you so much for having me here. I am really looking forward to my trip to your country. I've never been to India, and I'm looking forward to coming there in November. Between now and then, though, I do make myself available for follow up, whether it's there on the Facebook Live chat. That's a place to put it. But you can also reach out to me through my website, which is waltfritz.com. Send me messages, send me questions. I've got tons of podcasts on my website, tons of linked to videos. I love being invited on speech pathology podcasts to kind of share my world. One of the coolest ones I was able to do was one. It was called The Agentic Voice, and it's a podcast done by two PhD SLPs on the concept of emotion-based work, of trauma-informed therapies. And I was really honored that they saw the potential of this feeding into that trauma-based therapy and how touch can be something to help with those issues and how to work with trauma with touch-based as well. But lots of good podcasts, etc. All right.
That's great. So there were some other questions like what are the key techniques that you use in manual therapy for voice and swallowing therapy? They were asking if there are any specific exercises that you have to prioritize if you want to work on swallowing efficiency. How do you ensure performing this manual therapy and being cautious and not create a lot of tension on the patient or muscle? What are the standardized protocols for manual therapy and something on self-management? I think all this we are looking forward to meet everybody in person whenever we meet in November. So I think you will be able to ask more, see how each of these protocols are performed or how modifications can be done. So yeah.
As you were telling them, it's like you're just like you expect me to remember all those, and then you
No, I'm
gave the
gonna.
disclaimer. No, it's fine. And by the way, if you do have any of those questions that you want to put on the Facebook Live comment section, I don't mind trying to handle some of those. We
Okay.
certainly talk about the routine, the techniques, the precautions, the safety, etc. We talk a lot about that in the
Yes,
class.
because they have to be in person, as in when you teach them, they get to know about it. So I think it's going to be a great conversation once they are in person with us. So I think that's what we are looking forward to. So
Great.
before we conclude, Walt, do you have any final thoughts?
No, I think I'm talked out right now.
That's great.
And I just I'm looking forward to meeting people there. And if you're on the fence about taking the class and you want to ask some questions, feel free to reach out to me through my website. Okay.
Definitely. So
Okay.
on behalf of SLP Quest and all of us around here today, I want to extend our deepest gratitude to Walt for sharing his experience and insight. It has been an incredible experience or sharing of your experience. I also want to thank our participants for their engagement and questions they have put up, and we have tried to make most of it so that we can discuss here and you get benefited. So remember, SLP Quest is bringing manual therapy to India in this November 2025. Don't miss this opportunity to learn directly from the expert himself. Thank you all, and we look forward to see you again. So I think there are details in the slide. You can register for the upcoming training session on manual therapy for voice and swallowing disorders.
Great. Thanks so much.
Great. Thank you. Can we take a picture? Can we request all the participants to switch on their camera and we take a picture with Walt? Jocelyn, can you stop sharing the slide so that we have everybody?
Yes, ma'am.
I request all the participants to switch on their camera so that we have everybody. Jocelyn, are you taking a picture?
Yes, ma'am. 1 second. Can you take screenshot? Yeah. Take screenshot.
Yeah. So I think I request everybody to switch on their camera.
Well, you're not going to get all of them, I guess.
Yeah, that's okay. Anyways, thank you, Walt. Nice talking to you. So see you in
Nice
November.
meeting. Great.
Nice meeting
Okay.
you.
Great.
Great.
Bye.
Bye.
Thank you, sir. Thank you, ma'am.
Thank you, everybody.
Thank you, everyone. Thank you.